cells and binds to fibrin. The plasminogen makes contact with its binding site, which is near the TPA binding site, and as you know, free TPA is degraded in liver or inactivated by PAI1. After contact with fibrin, I should say this is a cool cartoon that was developed by a colleague at Genova. The plasminogen molecules opened and further binds with fibrin, cuts the peptide bond to convert plasminogen to the active plasmid, which is the true fibrinolytic, and then of course it does its work chewing up the fibrin. And this came from some paper published by Coleman in 2008, who, interestingly enough, many years prior to that, discovered a way to produce TPA exogenously from a melanoma cell line, and then that led to the use of thrombolytic or fibrinolytic drugs for various conditions, not stroke initially, pulmonary embolus and DVT, but many of us have said things we've regretted in the past, and this is probably one that maybe the person that said it regrets, but maybe not. He said back in 1983, there's probably little that medical treatment can do that alter the immediate prognosis of stroke. Probably that was, well, you know, things changed and the field's changed dramatically since then. And of course, all of this stuff has happened since then. The streptokinase, and of course, we sort of lagged a bit behind myocardial infarction, TPA, asterisk for intraarterial urokinase, intraarterial reticulase, tenecteplase, EVT, and then more lately, reticulase again intravenously for stroke, along with extension of the time window with imaging. And this is not a tenecteplase study, but this is just to show you the results from this study, which was one of the original trials that showed that endovascular therapy was effective for LVO stroke. If you look at the rate of recanalization at 24 hours in the TPA arm alone, it was very low, particularly in the LVO. And that has led, even before that study came out, some of us to look at testing a lytic that maybe was a bit more effective. And again, tenecteplase has been in use for quite some time prior for myocardial infarction. And some of you would know that it's a very close cousin of alteplase, tenecteplase. There are only 6 molecular substitutions, which potentially give it some benefits for stroke. Probably the biggest benefits, the practical benefit, is that it has a longer half-life, so we can give it as a single bolus, which typically means in a chaotic situation you can give it more quickly. And there's some other benefits as well. Some of the early work was, the first work was done by Clark Haley and team in the US. We started using it quite early in Australia, and you can see the final study there by Mahesh Kate was with Ken Butcher when Mahesh was still in Edmonton, but he got very cold and went back to India. You'd probably be familiar, this was the first randomised controlled trial of tenecteplase for acute ischemic stroke, which was done more than 10 years ago now. It was done at 3 Australian centres. It was probably the first time that perfusion imaging was used to select patients. Basically we showed that the 0.25 milligram per kilogram of tenecteplase had higher rates of reperfusion and early clinical improvement than did TPA or 0.1 milligram per kilogram of tenecteplase, which was the dose that was thought to be bioequivalent from small animal stroke studies. Many studies since then, the red there I have because they're the 2 studies where a dose of 0.4 milligram per kilogram of tenecteplase was used, it was shown to probably be harmful in patients with more severe stroke in the second NORTEST study. So it seems that 0.25 is certainly a safer dose than 0.4 milligram per kilogram. So we started with those small studies that I described and eventually ended with the phase 3 clinical trials. And Australia being relatively small, and we're a bit slower than some of the other studies. And you'll note TRACE 2, which was done in China with a Chinese-produced tenecteplase, as well as the Canadian trial finished before TASTE. So there were four phase 3 trials of tenecteplase versus alteplase in the early time window, 4.5 hours after stroke, that all essentially had the same results. The tenecteplase was shown in each of those trials to be non-inferior to alteplase for an excellent outcome at 3 months. These are some of our TASTE sites, and you'll recognise a couple of people who are speakers here today, Ken and Henry Marr, who that was in his pre-weight loss days. He looks a bit chubbier there in the face than he does now, so that fits in with Jeff's mention that some of our photos are a bit outdated. And we similarly showed that tenecteplase had a slightly higher rate of Rankin 0 to 1 at 3 months in patients with perfusion imaging selection. So we were the only trial that used perfusion imaging selection as an inclusion criteria. So 3% higher rate of Rankin 0 to 1 at 3 months, quite high rate of nearly 60%, but that wasn't statistically superior, but it was not inferior. And just by chance, sometimes I always say every cloud has a silver lining, although we were beaten to the punch by ACT and TRACE 2, when we added our results to the study level meta-analysis, tenecteplase was shown to be superior to alteplase in terms of Rankin at 3 months. Not by a lot, but if you treat a lot of patients, it's certainly significant. For every 25 patients you treat with tenecteplase rather than alteplase, one more patient will have an excellent recovery at 3 months. We had a very nice editorial written about TASTE by Kaz Toyota from Japan, and he said, is this the last piece of the puzzle? Well, it wasn't even the last study within the 4.5 hour window. When we published TASTE, TEST 2 was published, a British study was published not long after TASTE, and then Li Ping was involved in the somewhat ironically named original trial, which had a very similar protocol to some of the other studies performed prior. And of course there are a number of late window trials which you would know about. Timeless, which was a US study which Ken Butcher was on the steering committee from. Very short time window between tenecteplase and thrombectomy, almost impossibly short. One suspects that patients were consented on the way to the cath lab. It was about 15 minutes, so really didn't give tenecteplase time to work. And to show that that was probably the case, that the short time between lysis and thrombectomy didn't really give lysis a chance to work. The TRACE 3 study, which was pretty much the same network as TRACE 2 in China, didn't provide EVT for LVO, but gave intravenous tenecteplase versus no lytic, and not surprisingly, they showed a significant improvement in outcome. Eternal, again, we were too slow compared to the Chinese, and we stopped our study early because of various reasons, but lack of equipoise in terms of giving lytic to patients, particularly in the early time window. That's about to be published in Stroke, and another Chinese study run out of Shanghai called the Chablis study. I came up with the acronym, being a bit of a wine lover. Exactly, the CH stands for Chinese. Some people find it hard to pronounce, particularly in China. But it's very nice to drink Chablis if you haven't tried it. And that study, interestingly, showed benefit with tenecteplase only in the non-EVT patients. If anything, it looked like there were worse outcomes if given before EVT. And I think, given that there's still some questions to answer in the late time window with tenecteplase, there's a very large 1,300 patient study which will begin before the end of this year called Tenacity, which is sponsored by BI and will be worldwide. I'm pretty sure Vietnam's involved, I think China will obviously recruit many patients, but they will be capped at 20%. So hopefully we can recruit 80% of the patients in the rest of the world in a timely fashion, because I suspect China will recruit 20% pretty quickly. That will be in patients with favourable perfusion imaging, 4.5 to 24 hours after stroke, with LVO or non-LVO, but the caveat will be that patients will only be allowed to be enrolled with LVO if there are more than 2 hours between lytic and EVT, which essentially means patients that are transferred from primary stroke centres to a comprehensive stroke centre. And as you saw on the map of Australia, which some of you might not know, but the surface area of Australia is only slightly smaller than the US and China, but there are very few people, particularly in the middle of Australia. So in Australia, many patients are 12 or more hours away from an EVT centre. So this is really likely where tenecteplase in the late window will benefit LVO patients where there's a long delay. And in the last, nearly 10 years ago, tenecteplase was licensed in India. It's produced by an Indian company called Genova. And that drug is approved in India at a slightly lower dose, 0.2 milligram per kilogram, based on some dose-finding studies. And there's been a fairly large Indian registry of over 1,000 patients that Leonid Churalov and I helped the team analyse, which interestingly shows very low hemorrhage rates with pretty moderately severe strokes, so interesting results and good outcomes. And just to tantalise you, this will be published soon, I hope, if we can get Professor Metcalf to recover from his rotator cuff injury. Apparently that affects his typing speed. He's probably the world's leading sort of lab fibrinolytic guru based at Monash in Melbourne, and he's looked at the Boehringer produced Metalise and compared that with both Indian produced tenectase and also the two Chinese tenecteplase variants. And I'm not showing you all the results because it's still a bit confidential, but basically if you look at clot lysis activity in the lab, there's very little difference between any of those four lytics. So that's all very interesting, and I've probably gone more quickly than I expected, but it's not such a bad thing.